welcome, Navigator Nation. It's good to see you again. I was afraid for a minute, but we have made it up here now for our second consecutive episode of BreatheTV. As you can see, we're in a little bit different surroundings now. Maybe we'll call it Navigator Studio. I don't know. We're still waiting on that Netflix deal. We'll have to see how that goes, but not quite everything where I want it to be. But we have definitely made another step forward in this new season of navigation. For those of you new to the program, my name is Mike Hess. I'm a respiratory therapist, registered pulmonary function technologist, and COPD advocate in the state of Michigan. Work alongside with several groups trying to improve access to educational resources, medications, all the therapies that everybody needs to breathe a little bit better, breathe a little bit easier, and get what they need. Every other week or so, now that we're in our new season, we are meeting here live on Facebook so that we can go over some of the latest news of the last couple of weeks. We will tackle a topic of the day. In this case, we're going to be looking at a variety of the medications that we use for appropriate COPD management. And then we'll have some time for your questions and answers live from a respiratory therapist, COPD educator type person. So without further ado, if I can, part of the issue is I have discovered that my little clicker, my little remote, doesn't fit into all the ports with everything else that I need to shoot the video. So I'm working on getting a port expander kind of thing, and hopefully it won't be as much leaning over going forward. But in any event, the first thing we're going to talk about today is something that I hope you have already done as we are in the midst of flu season, and that is, of course, getting your flu shot. I know it is often a controversial topic. Any kind of vaccines for various reasons have become controversial in the last few years. But honestly, from a public health perspective, from a respiratory perspective, from a COPD perspective, vaccines are potentially one of the, if not the greatest public health innovation of all time, and flu shots are certainly no different. We talk a lot every year. There's that controversy about, well, how effective is the flu shot? Should I get it? Why should I get it if it's not going to bother me? What about this? What about that? A new study that just came out of, I believe it was Canada. Yes, Canada. Takes a look specifically at the effectiveness of the flu vaccine in the COPD population. This was, of course, a couple of years ago, but they looked actually over the course of 4 years to try to average out some of the issues with the seasonal variations in flu shot effectiveness. So over the course of 2011 to 2015, they looked at a couple of thousand COPD patients, people living with COPD, and found that in their scientific terms, the adjusted analysis showed a 38% reduction in influenza-related hospitalizations in vaccinated patients versus unvaccinated patients. 38% fewer admissions to the hospital. That means that you are more than 1/3 less likely to go into the hospital if you get your flu shot. On top of that, they also found some improvements in those people, as we try to impress upon everybody. Even if you get the flu, it's usually much more mild than if you had gotten that same strain of flu without the flu vaccine on board. And this study also bore that out as a secondary conclusion. They found that those people who were not vaccinated experienced higher crude mortality, which means they were more likely to pass away from the flu. And they were more likely to have a critical illness, end up in the ICU, perhaps on a ventilator, that sort of thing. So again, it is absolutely important for everybody, as many people as possible. You know, of course, if you have a known allergy to something in the flu shot or things of that nature, of course you have to be careful with that. But that's why it's so important for everybody else to go out and get their flu shot, so that we're not passing those things around. Even with flu vaccines on the market, make sure you're doing your good hand hygiene, you're covering your mouth when you sneeze or cough and that sort of thing. But the bottom line is we are still what we is usually considered the peak of flu season. It's not too late to get your flu shot. It's a bit on the late side, as in I'll put on my parent hat for a minute and shake a finger. I don't like to do that, but that's how important this is. Get your flu shot as early in the season as possible, but definitely it's not too late right now to go get it. We're still in the midst of flu season until about May, so we have plenty of time for people to get exposed, and so we need that protection. So moving on to something that is a little, well, I don't know if I'd say less controversial, but maybe differently controversial, is that I'm just doing a quick check here to see if anybody's asking any questions. You can go ahead and get your questions in now. If you ask them directly on the video, it is a little bit easier for them to see. But I will still make every effort to get everybody's question answered before we close off today. But we are going to talk about a brand new study that came out regarding e-cigarette use or vapes. These have been a very controversial topic over the past few years. They've been on the market surprisingly a long time. I saw some evidence that they've been out since I think the early 80s, if not maybe even a little bit longer. But over the last 5-ish years, they have really gained a lot more attention for a variety of reasons. They're viewed as being a safer alternative to traditional tobacco cigarettes because it's a vapor rather than smoke. So a lot of people think of them as a safer alternative. There's been some talk about can they be used as to help quit smoking, because you can adjust the level of nicotine in the juice, they call it, the e-juice that goes in there, the vape juice. So there's been a lot of controversy about whether it is actually a good tool to help people quit smoking. And it seems like every week there's some evidence that comes out one way or another, and the pendulum keeps swinging back and forth. So the latest heavy hitter article that came out was published in the prestigious New England Journal of Medicine a few days ago, and that found about 886 participants entered this program, and they found that those people who used electronic cigarettes or vapes to help quit smoking, combined with counseling techniques and that sort of thing, were about twice as likely to quit and to remain quit after a year after the intervention. About 18% of the people who were assigned to the electronic cigarette group were able to maintain that quit for a year, whereas about 9.9% of those people using the more traditional nicotine replacement patches and that sort of therapy were able to maintain that quit. In addition to that, much like we saw some secondary outcomes with the flu stuff, we see some secondary outcomes here as well. We see that the electronic cigarette group reported greater declines in the incidence of cough and phlegm production, which means more people were coughing less and having less of that junk build up in their chest over the course of the 52 weeks. And then also there were no significant between group differences in wheezing or shortness of breath. So as far as follow-on effects, this did seem to be a fairly successful intervention. This group was in the UK. They used nicotine containing juice of 18 milligrams per milliliter, which is, I believe, as if we're talking about juices, about middle of the road kind of stuff. And then we're able to titrate down with that after the starter kit. Interestingly, they also looked at how many of the group had previously tried to quit smoking. They found that about 75% of both groups had tried to quit using nicotine patches in the past, and about 40%, again, in both groups, had previously tried to use vapes, these e-cigarettes, to quit. And so these were people who, by and large, had tried to quit before using some technique. And so this was a second quit, which may also kind of skew the data a little bit. It's difficult to say. There are some other questions in here that the survey team was very open about, saying that perhaps people had tried smoking or nicotine replacement before, trying to quit smoking with nicotine replacement, had failed, and now they have kind of this negative impression of that. And so then when they try with the electronic cigarettes, that's viewed as a superior method. And so then they're more likely to quit, more likely to stick with it, more motivated, all that kind of stuff. Interesting questions brought up here. The biggest concern that a lot of people have is summed up in this paragraph here. Or no, excuse me, this is another benefit. Among those people who hadn't fully quit, those in the electronic cigarette group were more likely to at least reduce their smoking intake or their smoking consumption rather than those in the nicotine replacement group. But it is unclear whether this affects future abstinence. So those people who are using the vapes to quit were definitely able to smoke less than the nicotine replacement group, but we don't know how that follows on after a year. One of the biggest concerns that was brought up by in an editorial that kind of accompanied this article was the idea that people were able to quit smoking cigarettes, but participants who had quit smoking cigarettes at the 1 year mark, 80% of those people who were using electronic cigarettes at the 1 year point were still using electronic cigarettes, whereas only 9% of those people who were using nicotine replacement were still using nicotine replacement after a year. So that kind of brings up the question of whether we look at these treatments as a true aid, a tool, or if they're really more of kind of a transfer of addiction kind of thing, and we're basically trading one devil for another. Because yes, they quit smoking, but they're still taking in nicotine. They're still taking in a lot of the chemicals that we don't really know what the long-term effects are. There's some evidence in animal models that exposure to some of these juices can create the same kind of damage that nicotine does. The general consensus right now is that these devices are safer than traditional tobacco smoke, because the idea is if you have a vapor, it's a little bit better for you than smoke with all the particles and all that kind of stuff. But we also have plenty of cases of occupational exposure to fumes and things like that where we don't see the effects until 10, 20, 30 years down the road. And we simply don't have the body of evidence to show that these things are definitely safe, or even that they're definitely safer. So what that boils down to is, from a personal perspective, I'm not here to lecture people about that sort of thing. If that's what you choose to do, then that's fine. But from a clinical perspective, I have to advise that we simply don't know what some of the long-term effects are, whereas we do know what we have established the safety of a lot of the other things that we have out there. Some of the medications we use, we know that nicotine replacement is generally safe, with the exception of the potential skin irritation with patches, minor side effects like that. So it's really comes down to kind of a risk-benefit sort of thing. Lastly, on the news front today, some good news from the pharmaceutical world, and I will disclose here that I have received some minor speaking fees from some companies in the pharmaceutical world now. We're trying to get people to be more mindful of their inhaler technique and that sort of thing, including the company I'm going to talk about here. They did ask me to participate in an advisory board last December. So I did get a little bit of a lunch with that sort of thing. But from an objective standpoint, this should be considered pretty good news. For the first time, we actually have a true generic equivalent to the longtime superstar combination medication called Advair. Advair has been on the market, I want to say about 20 years now. Was a long-term bronchodilator, which we'll get into a little bit more. That's actually the topic of our show today. Long-acting bronchodilator combined with a corticosteroid, which we'll talk about both of those as we go on. It's been on the market for a long time. The difficult thing with inhalers, especially since a lot of these have the FDA kind of got rid of a lot of they switched from the CFC propellant to what's called the HFA propellant, theoretically protecting the environment. In order to get a new drug to market, you have to prove not only the medication is equivalent, but the device it's delivered in is equivalent. And that has been a holdup for a lot of medications. About a year ago, we saw the release of Air Duo, which was not a straight up equivalent. The dosages are a little bit different because it comes in a completely different kind of inhaler. But this new device, or this new medication called Wixela, It comes in a device called an InHub, which I forgot to throw a picture on here, but you can search up Wixella. I've got it on the screen there. You can get a picture of it. It looks very similar to, actually it looks kind of like if you took a traditional discus, if you took one of these deals and kind of squished it into a bit more of a triangle. So it's a very, very similar thing. It opens up, works very similarly. The dosages are the same. It is truly a generic, straight up generic equivalent, which should help out. A lot of people get access to these medications on their various formularies for a lower cost. That is a huge issue right now. It's one of my personal pet projects here in Michigan. We're working very hard to improve access to these medications because a lot of times they come on and go off these formularies without a real scientific backing to it. And groups like the COPD Foundation have come out and said that's not acceptable. We have people who are well controlled on particular medications, and we can't just be switching them off willy-nilly just because some company got a better deal for a month. But having a generic on board will help with that. This is expected to hit the market on the second half of February. And that's really, I guess that's really the biggest detail on that. It's going to be good news. First generic, first in a long time. Been waiting for that to come onto the market for several years now through the approval process. And it's exciting news for everybody in the respiratory community, asthma and COPD alike. All right, so that is our news section for today. All right, so we're just getting everything back where it needs to go. And we are going to be talking about one of the... Every time I think I got this thing figured out, I go in a different direction. We are going to be talking about one of the frontline methods of care in COPD, and that is inhaled medications. Inhaled medications, while nobody really likes to take prescriptions or anything like that from time to time, these are one of those things that they really do help in a lot of cases. They help, I think I may have thrown this out there last week or 2 weeks ago, last episode, but one of the most well-known COPD advocates out there, Dr. Gene Ramos from out in Iowa, frequently talks about how it's exercise that allows her to live, but it's medications that allow her to exercise. So these are kind of a foundational thing in COPD care and a lot of other chronic lung diseases. We've got to have those airways open. We've got to have those airways under control in order to do the things that we want to do to actually improve quality of life. And oftentimes, these medications alone can help with quality of life measurements. They work to open up and get air moving more easily, which in turn creates a more effective cough. They put people at less risk for exacerbations in some cases, flares that end up in the hospital. So these can be very effective tools. They are one set of tools, but they can be very effective. The downside is there are so many of them. This is the latest poster from the Asthma and Allergy Institute that came out about last year. It shows a lot of our medications here. Unfortunately, it's already out of date. Obviously, we saw that we have a new generic inhaler coming out onto the market. I can even tell you we had this came from our professional organization. A professional organization, the American Association for Respiratory Care, what we call our post-acute care group that looks at chronic disease management and that sort of thing. Our section leader came up with that literally 2 weeks ago, and again, that's already out of date. That was an improvement because that actually has some of the nebulized medications on here that aren't on this poster, but again, it's already out of date. This stuff happens so quickly. It is very easy to get confused. It's very easy to get disoriented, and it's very easy to lose track of what you should be on. So we're going to take a look first off at why you take some of these medications and why they're so important. First off is this idea of bronchospasm. This is one of the biggest components of asthma and COPD care. And what we see here in this animation is that this is a cross section of an airway. And what we see is while it's a little bit filling up with mucus and that sort of stuff too, we also see those little red bands around the outside. Those are actually muscles that surround your airways. And what happens when your lungs encounter an irritant, whether it's tobacco smoke or wood smoke or whatever it is, they tend to clench down in order to protect some of the more delicate structures like the alveoli, where the actual oxygen goes in, carbon dioxide comes out. They work to protect those parts of the lung by physically closing off the tunnel, basically. Unfortunately, when that happens, obviously there's not a lot of air that's going through there too, and oftentimes people will have some chronic level of bronchospasm in their lungs, particularly with asthma, but also with many types of COPD, many individuals with COPD. And so our first set of medications that we're going to look at are called bronchodilators, because what they do is they actively work to remove they actively work to remove that bronchospasm. They work to reduce those, relax those muscles so that the airways open up again and you can get more air in and out. So this first row here, we call them the beta agonist bronchodilators, or the beta 2 agonist bronchodilators. You'll hear a lot of these medical terms come around. Sometimes you'll hear beta adrenergic. We clinicians love our $10,000 words, and with lots of syllables and everything else. So, but they basically all work on the same thing. They're kind of cousins of adrenaline or caffeine or other stimulants like that. They kind of stimulate that whole fight or flight reflex to get your lungs open up. The downside to these is sometimes they also have a little bit of heart side effects. Again, you run into those fight or flight things, and that gets your heart rate going too. So sometimes we see a little bit of that with these, and this is the class that includes our old friend albuterol and its various different flavors and brands. Works very well, but has some of those side effects sometimes. So we also look at another class of bronchodilators that does basically the same thing, just on a slightly different chemical path in the body. My old respiratory instructor used to describe it as first the fight or flight reflex, or also the curl up, and then this one is the curl up and die reflex. This is these are your what we call muscarinic antagonists or anticholinergics, or all those other fancy words. The cholinergic pathway is, again, that kind of curl up and die reflex that, again, you still get some relaxation because everything, you got to be able to move that air if you're in a defensive posture. And these are arguably the more important tool for COPD care. It's a little bit of an editorialization. The evidence is weakly biased for these anticholinergics, especially for long-acting medications, which again we'll get into in a few minutes. But these work, we often use them as kind of a belt and suspenders approach, because if we can pull the airways open and push them open at the same time, then why not? Works very well. These mostly are long-acting types of medications. We do have one short-acting one called Atrovent. Many people are familiar with the combination of albuterol and Atrovent. Oftentimes when it's nebulized, it's referred to as Duoneb, which was an original brand name of that combination. We also have Combivent in an inhaler. So you may be familiar with it under those names. Albuterol, I guess I should go back and read off some of these names. Ventolin, ProAir, Proventil. Those are all different kinds of albuterol, kind of like Coke and Pepsi in a certain way. They have the same active ingredient, but they just have some different other ingredients that can change their effect, their impact on people. But at any rate, these mostly are long-acting medications and used for control and maintenance measures. So when we start talking about a lot of these medications, again, I'm throwing these words out there: long-acting, controller, short-acting, rescue. What does that all mean? Well, these medications, for a very long time, albuterol has been around for a very long time, and we use that to open up the airways, but it is metabolized fairly quickly. In the best case scenario, the albuterol usually only goes for about 4 to 6 hours. It's kind of enough to get you over a hump, but for people who have this chronic bronchospasm all the time, that means you're kind of tethered to taking this medication over and over and over again during the course of a day. So scientists and chemists and everybody else worked very hard to try to stretch out that long-term, or stretch out that effect, try to get it so that it wasn't metabolized as quickly, wasn't used up as quickly. And then we came up with this idea of these controller medications. Controller medications last anywhere from 12 to 24 hours and basically open up your airways to give you what I call a higher baseline. Your worst bit of breathing should be higher if you're on an appropriate controller medication than if you are without it. Now, you also still have, you all are also still able to have short-acting inhalers called rescue medications. Those are generally speaking for if you're having a bad day, if it's an ozone action day in the summertime, or if it's polar vortex day, Arctic vortex, whatever the thing is called, and it's 20 below zero, and you go into bronchospasm a little bit. That's what those medications are for. We have taught for a very long time that, well, maybe you should take these rescue inhalers before you take your controllers, and there's still a lot of controversy about what the proper dosing order is, because some people seem to respond a little bit differently. But in general, we want everybody to have their optimal controller medication and then follow along with rescue medication as needed. And that's what those bronchodilators are for. We've got some that last for a long time, some that are for rescue. One class of medication that, oh, it's not scrolling. That's what's going on. That's why it doesn't look like anybody's talking. It just wasn't auto-scrolling like it used to. And we'll throw that in the bin of another thing that Facebook has messed with without telling anybody. So, this third class of inhaled medications, which we're going to talk about, is called inhaled corticosteroids. And what these do are, just like any other steroid, they work to reduce inflammation. When you have, again, these irritants in your lungs, not only do your lungs have those muscles to help to go into bronchospasm and close everything down, but a good example, I keep doing this fortunately or unfortunately. I scraped my hand on something the other day. I'm not even sure what it was offhand. But when you have that irritation, that injury response, your body's natural reaction is to kind of get red, kind of swell up a little bit, brings a little bit more blood to that area and some other inflammation things. And that's part of the healing process. That same thing happens inside of your airways. When you get those irritants inside your lungs, they start trying to protect themselves. They go into bronchospasm and they build up these inflammation areas, which has a very similar effect in that it closes down, as you can kind of see in the animation here, closes down the inside of that airway. And when you have less space for that to maneuver or for that air to get in and out, it's much harder for it to get air in and out. You get shorter breath faster, it's more difficult to cough, all kinds of side effects like that. So, one thing we can do is remove the irritant, and that's why we do encourage everybody to quit smoking as kind of the mainstay of care. But we can also work on reducing inflammation with medications. If people are still smoking, or if they've kind of gone into that cascade where they have this chronic inflammation all the time now in their lungs, we can actually do inhaled corticosteroids that work specifically on those areas inside the lungs to bring down that inflammation and open up the airways that way. These are, again, generally well tolerated. We try to keep people's exposure to steroids as low as possible in general for a couple of reasons. First off, while inhaled medications do tend to stay in the lungs, which is why it's nice that we can use these steroids, they don't stay there forever. When we have people, this is probably more of an issue when we talk about asthma in kids and things like that. When you have people who are on these steroid inhalers for years and years on end, some of that extra stuff kind of goes out into the bloodstream and has what we call systemic effects. Usually these effects are really confined to the lungs, but sometimes they do go out and cause some of those traditional things. Anybody who's ever been on prednisone or something like that knows what systemic steroid effects are. Hunger, irritability, energy swings, all that kind of stuff. And so even with folks who aren't kids, we do try to minimize their exposure. In addition, there's some evidence that people with COPD are at a little bit higher risk for pneumonia when they're on inhaled corticosteroids. Again, it's a relatively minor risk, and we have to look at what the risks and the benefits are, especially when we start getting into really complicated things like the overlap of asthma and COPD. Many people with COPD have some degree of what we call reactive airway or airway reactivity, which is kind of like asthma, can be helped by these steroids. So it's difficult to kind of pin down who should be getting what, basically. But that is the role of these medications, to bring down inflammation. These are only considered controller medications. They do not kick in very fast at all. They need some time to work their magic, and you need to sustain that over a period of time. So these do not have a short-acting version, which makes them different. Probably one of their biggest differences from the true bronchodilators. So we also have combination medications. We look at this whole row, and a lot of times we can get 2 or now even 3 different medication classes in one device. The nice thing about that is, first off, it can be lower copay for those people who are paying copays. It's easier to dose. Instead of taking 2 or 3 devices, you can just take one, and you can take them at the same time, and it's a lot easier to do that. And we often see that a lot of these medications the clinical word would be potentiate each other. They work together to kind of be greater than the sum of their parts. They're a little bit more effective when they're done together, and so we try and do them together. Again, it's the best combination and the best device for each patient. That's something that we really need to focus more on in the clinical realm, and in basically throughout the whole continuum of COPD care. We need to be focusing more on matching up the right person with the right therapy, including the device, so that we can get you the best care that you possibly can. One thing that you probably have noticed that I haven't really talked about very much is nebulizers. Nebulizers are a very, very effective tool, particularly for rescue, in my opinion. They work fantastic for rescue because their biggest advantage is they are far less sensitive to technique. A lot of these, and we're going to touch on this briefly, a lot of these inhalers require a specific technique in order to get your full dose of medication, whereas nebulizers are kind of designed they'll push stuff out and you breathe in as much as you can, and they work a lot better in that regard. However, we don't have as much variety when it comes to different molecules and things like that, and sometimes that's an important consideration. A lot of times we look at these where we say, well, this person has been on one of these anticholinergics and it didn't work, so maybe we should just give up. But we shouldn't, because everybody has different tolerances, everybody has a little bit different sensitivities, and we don't always have a very clear idea of how everybody's individual chemistry is going to interact with a particular medication molecule. So that's one strike against these nebulizers, is there is less of a variety. For example, up until last year, we did not have a long-acting anticholinergic in a nebulizer. We now have 2, but we only have 2, where you can see, if you look at the chart, we have 4 or 5 in the inhaler. So there's a little bit less to talk about. All of the same drug class things are still applicable in the nebulizer realm. There's just not quite as much detail that we need to talk about as far as technique or that sort of thing. Next up, I really need to get that remote working. Next up is this class down in the bottom corner, and you can see this whole bottom row. The biggest difference between these medications and what we've been talking about so far is that these are not inhaled. What this drug in the corner is we freeze up here? Hope not. This drug in the corner here is called roflumilast. The brand name is called Daliresp. And what that does is it's an anti-inflammatory, much like the inhaled steroids, but it works in a different chemical path. It's what is technically called a PDE4 inhibitor. And a little bit concerned. Yeah, everything is kind of frozen up there, huh? Aw, come on. Well, it wouldn't be a live stream without some kind of technical difficulty, I guess. This thing's really not working. Alright, well, we'll cut some of that out in the edit when we get this up onto YouTube tomorrow or soon. Let's see if I can fix it. Hey, there we go. Now we're back. All right, so what was I rambling on about? Oh, this is called a phosphodiesterase 4 inhibitor. Brand name is Daliresp. Generic name is roflumilast. Works to decrease some of that inflammation, but is not inhaled. And so that means that there is this potential for systemic side effects again. They are different than those that you would normally associate with steroids. One of the most common things is it causes a lot of gastrointestinal problems. I've also heard some talk about some anxiety, depression issues. The thing far and away, the thing I hear most about is the gastrointestinal stuff. But again, this could be an option. We usually use this as a kind of a later line of treatment. We have the stuff we do in the front lines. We have the first rounds of stuff. And if those don't work, then we kind of escalate a little bit. Daliresp is definitely one of those things that is later on in the arsenal as we're trying to cut down on exacerbations and admissions and all that kind of fun stuff. The last thing, and hopefully, yep, okay, we're still live. We're hanging by a thread, but we're still going. The last class of medications here, maybe, there we go, are these biologics. And these are injectable things that have a variety of different effects. A lot of them are anti-inflammatory. A lot of them do various things. The issue here is that many of these have been developed for asthma, and they are very effective in asthma cases. The biggest difference between asthma and COPD is that asthma, theoretically, you can reverse back to your basic lung function, your normal lung function, with an appropriate treatment regimen. Whereas COPD, you cannot. And so a lot of the tests of these biologics, a lot of the studies in COPD, in the chronic obstruction that's not reversible, have been less than impressive. There was one recently that they were really pushing for, hoping to get a new FDA approval specifically for COPD. We're not able to do that because it just wasn't shown to be effective enough. Not entirely sure why this the whole realm of biologics is relatively new, particularly with respiratory disease. And by relatively new, that still makes it 10, 15 years old sometimes, but it takes time to develop this kind of data on stuff and to figure out exactly what the right answers should be. So it's tricky. So we're not going to go into a lot of detail there, but this is a class that is available. And then the one thing that's on the poster that is not a medication, and therefore I did not highlight, is this idea of bronchial thermoplasty, which again is arguably a little bit more of an asthma thing, but the application of heat, as in thermoplasty, and also cold, have been, and we're starting to look at some of that stuff in the realm of COPD as well to help with some of the bronchospasm or the inflammation, to open up the lungs that way. So, How do you know that you're on the right thing? Well, we've got two main classes of inhalers down here in the corner. You'll see the video that we did earlier this week. We dropped on YouTube and on our Facebook channel here called Spotlight on Dry Powder Inhalers, where we talk a little bit more detail about those kind of inhalers. Basically, to sum it up, you have a couple of options, which I will pick these two because this one is probably the one that has been around the longest and maybe a little bit more, maybe familiar with a little bit more people, called the HandyHaler, which is used for Spiriva. Basically, the way this one works is you open up the whole thing like I have it here, drop a little capsule that contains medication in there, close that, close the whole thing back up, pop it, open up half of it again, and take a big deep breath in and get that medication down into the lungs. And then you should probably throw away the capsule. Works very well. Nice option. What might be a little bit nicer is something like this. This is called an Ellipta, manufactured by GSK, which has a variety of their medications in there. Brio, Anoro, Trelegy, a couple of different, that's a situation where the same device can deliver a couple of different meds. The big advantage to this is it's not, you don't have to reload it. All of the medication is in here in a little tape. I often compare it to if you ever played with cap guns when you were a kid and you had those the roll caps with a little bit of gunpowder in there, and then that would just kind of spool through. That's basically what happens with this thing. When you crack it open, it pulls the top layer of the tape off, exposes the powder, and you just, again, breathe in real sharp like that. We can measure to make sure that you're using your dry powder a little bit, or making sure you're using it appropriately with this device called an in-check dial, which again I go into a little bit more detail on in the video down below. So check that out if you happen to be using a dry powder inhaler. For those of you who may not be using a dry powder inhaler, we also have devices to check that thing out. We have this other type of delivery device called a metered dose inhaler. This is arguably the most familiar medication, or the most familiar device to just about anybody involved in lung disease stuff. What this is also a very good device. Advantages over like a nebulizer: it's very portable. You don't need a power supply. You don't need a lot of stuff, but it is very sensitive to technique. This probably isn't going to show up real well on the video, but we're going to try it. If you puff one of these, if you watch what it does when you can kind of see it. That stuff comes out there very fast, which means that you have a very short window to coordinate the delivery of the medication with the inhale and everything else to get it where it needs to go. In addition, we don't often do a very good job of teaching people this stuff for a variety of reasons. It's not that anybody is actively saying, I don't care about those people, we're not going to teach them anything. Every clinician out there, from the primary care provider to the hospitalist to the pharmacist at the drive-through pharmacy, is under a huge time crunch. And sometimes we make assumptions about whether people can use these, know how to use these, or are going to read the instructions or anything like that. And so that's why it's important to, and this is why our next spotlight coming out next week is going to focus on these meter dose inhalers. These are very good, but they're also very sensitive to technique, and they're very easy to mess up. And the way we measure that technique, well, first off, we'll do a little bit of demonstration. The way you do a meter dose inhaler is you blow everything out. You're going to inhale and puff at about the same time. You can even inhale a little bit first, so that everything is open and nothing hits the back of your throat. And you take a nice slow deep breath in, like you're sighing or yawning or something like that. And then you do a breath hold at the end. So the whole maneuver looks a bit like this. More or less. how do we analyze that? Well, we have a very nice technique, just like we use these in-check dials for the powder inhalers. We have this gadget called the aerosol inhalation monitor, or AIM, or AIM. What the AIM does is lets us look at the entire process of using that inhaler, and lets us do it in a way that is very objective. It's not, our eyes will fool us sometimes, but we can get very accurate technique in with this device. It also gives us some really nice feedback right away. We'll turn all the lights on, get it all nice and pretty. And so what this will do is there's a little bit of distilled water in here, or sterile water, connected to this thing that looks very similar to most of the meter dose inhalers on the market, connected to this pressure tube. The device will be able to detect when I puff it and when I start inhaling, and make sure that they're in the right window. It can tell when I stop inhaling. It can tell how hard I'm inhaling, and then all I have to do as the clinician is hit this little timer to show that the breath hold is over. So, for demonstration. And this tells me that I do, in fact, know how to get all of that medication theoretically down into the bottom of my lungs. What usually happens, especially right off the bat, when people are new to their inhalers and they've watched too many episodes of House, or seen it in a movie or something like this, they inhale very deeply, very fast, like this. And I don't know if the microphone picked it up real well, but it gives us a different error, or a different noise, kind of an error tone, and tells us that we not only didn't coordinate very well, but we inhaled. Actually, that told me my flow was pretty good. I guess I need to try a little bit harder. But at any rate, nothing is even getting into our airways because it's all hitting us in the mouth, because the coordination is terrible. So let's see if I can get it where I can coordinate, but I'm still breathing too fast. Whoops. And you see it's got that bad noise again. This time I did coordinate pretty well, but I got red lights on the flow and the inspiratory time, and it's telling me that you got it into your mouth, but it hit the back of your throat. So this is a really valuable tool for us clinicians to really target what parts of those inhalation maneuvers need to be practiced and need to be retaught. So again, as I said with the in-check dial video, or the DPI, the dry powder inhaler video, if your provider's office doesn't have one of these things, they should. They're not terribly expensive. They're more expensive than the in-check, but they're worth it. They're worth it for good patient care. They're worth it to help keep people out of the hospital living their best lives. They're a very worthy investment. So the last kind of inhaler is the newest one that we have on the market right now, called the Respimat. This is made by a company called Boehringer Ingelheim. I have no idea if I'm pronouncing that correctly, actually. But this is kind of basically a mechanical nebulizer. It comes out much more slowly than a traditional meter dose inhaler. Let's see if we can. It's a longer plume, and it comes out more slowly, and in theory that makes it a little bit easier to inhale. The downside to this is because this is all launched by a spring, it can be a little bit hard to twist. And, well, there we go. Sometimes it pops open into the next dose, and so you get a little bit of a wasted dose. Now that I did it on accident, I won't be able to do it again on purpose. But what I can do is simulate something similar, where if your hand slips off of it and it happens to pop back, then half a dose goes spraying out into the room. So all of these devices have pros and cons. All of them work for the right people. Meter dose inhalers and such can have adjuncts like this thing. This is called a valved holding chamber, which really optimizes how much medication you're going to get into your lungs, because it allows you to have a bigger buffer with the coordination and do that proper inspiratory flow. We also have mini spacers like this. This is called an inflow cone. These travel a little bit better than some of these valve holding chambers, so people tend to use them a little bit more. Perfect world, you're going to use one of these every time, but at least use something like this every time. But the key thing to remember is that each of these medications, each of these devices has to match the individual. It has to match the things that you are able to do, it has to match the things that you need to do, and it has to match the things that are going to get you to adhere to your regimen. I've had people come in and say, well, that medication didn't work. I haven't been taking it. And I ask them why, and well, it tastes bad. When things taste bad, my wife can tell you this. She had me taking some kind of multivitamin horse pill that was like 8 pounds of pill, and it tasted horrible. And I said, I'm just not going to take that anymore. And so whatever it is, whether it's powders, whether it's the meter dose inhalers, the slow mist inhalers, whether it's a bronchodilator, whether it's a steroid, whatever it is, it has to match your needs so that you are willing and able to take it correctly and to, again, get that best result out of your medications. One last thing I want to emphasize real quick. Forgot to say it when we're talking about those steroids. When you're using an inhaled corticosteroid, you absolutely have to rinse your mouth out with a gargle, with a little rinse, swish, spit. We talk about a lot of different ways. Get that film back out of your mouth so that you don't develop this thing called thrush. And if you've ever had thrush, you know that is a really unpleasant thing, and you don't want any part of that. So that is our medication show for this week. Appreciate everybody stopping by today. We do have some time for questions, comments, concerns, all that kind of stuff. I'm going to scroll back a little bit here and say hello to lots of people. Hello to Kathy. Hope you're still with us. Shar, hope you're warming up a little bit up there in Canada. Susan from Green Valley, Arizona. Thank you for tuning in. Lisa from Sitka, Alaska. I don't think I've ever had anybody from Alaska before on any of these shows. Last year, and a bit into the year before that, I had a show called COPD Navigator Live. We have a group here on Facebook called COPD Navigator that is a patient-focused, patient-centered community for objective, evidence-based COPD information and support. Support is a key component to any kind of good chronic illness management program. So we try to cover all of our bases there. And this started as an outgrowth of that. I invite anybody who is interested to join our group on Facebook. If you're tuning in through the COPD Navigator page, there should be a link on the page somewhere, or we're easy enough to find if you search for COPD Navigator. One thing I can't believe I forgot to mention at the top of the show is that we did reach our 100 subscriber threshold on YouTube. So we were able to change our name. I had a channel. Many people may recognize me or know me as Mucophile. That's still my Twitter handle. A couple other things in that regard. That was an old brand that I had, and I just wanted to repurpose that with a lot of the COPD Navigator stuff. So when we hit 100 subscribers, they're allowing us to do that. And so you can see, and I got to switch back to the right screen here. You can see, because I still don't know my right from my left, we were able to do that. So thank you all very much for hitting up that YouTube channel. I really want this to become a thing, because we do not have enough COPD awareness in our community, in our state, in the country, and around the world. So I'm hopeful that I can bring some of that to everybody. And the kids tell me that these things like Instagram and YouTube and all that stuff are where it's at these days. So that is what I am trying to do. Scrolling back a little bit more. Bernadette, sorry I missed you before. Hello from the United Kingdom. Across the pond. That is fantastic. And hello to Giovanna too. So, Michelle mentions I use Stiolto. Stiolto is a relatively new drug. It is one of those ones that comes in this kind of device. It is a combination of our old friend Spariva that not only comes in the little egg, but also this kind of thing, which a lot of people find a bit easier to use, which is the long-acting controller anticholinergic, and a long-acting beta agonist bronchodilator. So it's got the two bronchodilators in one device. Works really well for a lot of people because it's got that slow mist, and it does have pretty good delivery device, and does not have the steroids, so it really is a nice option for those people who don't need the anti-inflammatory effect, and so we don't have to expose them to that higher risk of pneumonia. Michelle unfortunately has also had thrush, which I would not wish on anybody. I can't swear that I've had it myself, but I have heard a lot of stories from a lot of people who have had it, and it is not something that I would want to encounter in my life. So let's see, what else do we have here? We're going to check some of the other groups here to see if anybody has left a comment, just to see if again, if you drop a comment here on the video itself, it's a little bit easier to see to see and respond to, but we do have it going through a couple of other channels now. However, it does look like we are closing up shop for this week, this presentation. Tune in 2 weeks, where I should have had my little calendar with me, where we're talking about the topics, but we will be talking about, if I can get back on the right page here, I believe we're talking about oxygen next time. Could that be? Could be. There is a lot of stuff to talk about when we're talking about oxygen. There was, as a matter of fact, just this morning, I don't know if anybody is familiar with a gentleman by the name of Z-Dog MD, Dr. Zubin Damania from out in Las Vegas. He does a lot of medical awareness, tries to raise a lot of issues, and he was talking about medical myths and things like that. And the idea of the hypoxic drive theory came out, which is something that many people who are using oxygen and have COPD are sensitive to. So we're going to talk about why that is truly a myth, assuming that I am right. And the next one up, yes. The February the 20th, we will be talking about no O2. We're going to be talking about how to figure out if you need supplemental oxygen, how to use the different devices, because there is a little bit of a difference between some of these various things. We're going to be talking about concerns, issues, all that kind of stuff. So if you have any questions you want to get loaded up into the queue, drop them in the comments below or off to the side, depending on what kind of screen you're viewing this on. Maybe it's up there, who knows. Everybody's got a little bit different screen, so drop us a comment, drop us a question. We've got our topics lined up for the next couple of months now, but if there is something that you want to see either here on the live show, BreatheTV, or if you want to see in our little short bits, the spotlight segments, let us know, and we will definitely do our best to accommodate that. Make sure that you come join us in our Facebook community, COPD Navigator. Make sure you subscribe to us on YouTube. Make sure you do all the other hustle and flow kind of stuff. And doesn't appear like there are any other questions. I hope everybody has a fantastic rest of your Wednesday. I appreciate you spending some time with me. Go out there, stay warm, take care of yourselves, take care of each other, and we'll see you again in 2 weeks. Take care.